The next strip pad that we're going to talk about is going to be our glucose pad. So glucose. Glucose is the primary source of energy for the body's cells. We need glucose. Our body needs glucose in order to function, in order to metabolize, in order just to live. Excess glucose in the body gets stored as glycogen, and therefore when you get to a point where glucose cannot be used by cells for energy, the glycogen is going to be metabolized to ketone bodies to be used by the cells. So one of the byproducts, if there isn't enough glucose coming in, will be the glycogen. So blood glucose gets filtered through the glomerulus. It's a small enough particle, it goes right through that column, right through the sieve, into the glomerular filtrate. In that proximal convoluted tubule, the body is going to reabsorb it. It's going to pick it back up. It reminds me of, this is how, when I think of it as the I Love Lucy and the Candy Factory, right? You know, when a normal person is able to pull back up, when it gets a little crazy, it goes a little bit faster, but the body's like, oh, just kidding, I need that, and the body's pulling it back up and pulling it back up. And so the body in the proximal convoluted tubule is going to be reabsorbing almost all the regular glucose coming through the glomerulus in a healthy person. The renal threshold for glucose is 180 milligrams per deciliter. That means up to a blood sugar up to 180 milligrams per deciliter, your body will be able to reabsorb that after the, out of the kidney. So we'll be reabsorbing up to that. Anything in excess of that gets excreted into the urine. So anything higher than 180 milligrams per deciliter is going to end up as glucose in the urine. Glucose testing is primarily done to diagnose diabetes and monitor diabetes. So we have a lot of diabetes in this country. It's the primary thing we think of when we think of excess glucose in the urine. We think of diabetes primarily. If the body is not able to use the glucose as energy, it's going to metabolize the fat to the glycogen, like I talked about a few slides ago. So causes of glucosuria. The most common cause we're going to see is going to be so as I said before, normal urinary glucose, most of the blood glucose is going to be reabsorbed in that proximal convoluted tubule. Less than 20 milligrams per deciliter per day is going to be excreted in the urine in a normal, healthy person. So yeah, a little bit's going to get through, a little bit's going to go through, but overall in a whole period of a day, less than 20 milligrams per deciliter per day. The sensitivity of glucose on a dipstick is going to be, the chem strips is 50, the multi-sticks is going to be around 100. So because of that, when you're talking about less than 20 milligrams per day, milligrams per deciliter per day, we're never going to see that on a normal stick. So we're never going to see normal. When we see glucose on a stick, it means there's elevated amounts of glucose being excreted. So conditions causing glucosuria, we have prerenal and renal. Pre-renal, pre-kidney, and things that are happening in the body before the kidney. Renal, something happening in the kidney that's causing it. So pre-renal is going to be way more common. We're going to see pre-renal glucosuria way more often. In this situation, somebody has a high blood sugar, something's going on. Diabetes mellitus is going to be our most common cause of this. They have a high blood sugar. So because of that, what causes that is going to be a lack of insulin. Insulin gets formed in the pancreas, and sometimes it just doesn't form. People get to the point where their bodies don't create the insulin it needs. Insulin, when it's formed, actually is what allows the glucose to be able to enter into the cells and utilize. It doesn't actually break them down, but it attaches to the glucose and helps them cross the cell membrane and get into the cell in order for the body to use it to make energy. Without insulin, the glucose is going to stay in the bloodstream, and the bloodstream is going to become hyperglycemic. We're going to have hyperglycemia, high sugar blood. Oftentimes with diabetes mellitus, what happens is there's plenty of blood sugar, there's plenty of sugar floating around the bloodstream, but the cells themselves are starving because we can't get that blood sugar, we can't get the sugar into the cells without the insulin. So in a normal person, this is what we're looking at. We have arterial plasma glucose, about 100 milligrams per deciliter. Normal, right? 70 to 110-ish, depending on where you're at, your normal reference ranges. So 100 milligrams per deciliter. It gets through the glomerulus. The body says, okay, here it is back. The body takes it all back. So it pulls back the 130 milligrams per minute, goes filtered through, 130 grams per minute, gets reabsorbed out, and we have 0 coming out into the urine at the end, because everything that's going through is coming back and being reabsorbed by the body. Now, when we're looking at pre-renal glucosuria, we're looking at something like 300 milligrams per deciliter, so really, really elevated blood sugar. When we get that blood sugar so high, the glucose filtered, it's going to filter out 390 milligrams per minute, but the body can only reabsorb up to 350 milligrams per minute. So because of that, we have this extra 40 milligrams per minute being excreted into the urine that we cannot reabsorb as fast as we are making as fast as it's coming through the glomerulus. So pre-renal glucosuria primarily is going to be diabetes mellitus. Like I said, due to inadequate insulin production, the cells can't use glucose, so the blood levels are going to rise. Other abnormalities we're going to see ketonuria due to fat metabolism, so the ketones in the urine are going to elevate. Ketoacidosis due to the presence of ketone bodies in the blood. We're going to see an elevated urine-specific gravity by refractometer only. If you remember, big molecules make the refractometer bend more, which is going to create a higher refractometer specific gravity. Glucose does not affect dipstick specific gravity. Remember that. Refractometer, large molecules bend more. We're going to end up getting, sometimes the urine gets this fruity odor due to the presence of an acetone, which is one of the ketones. And you're going to have polyuria. You're going to have to urinate a lot. So you're going to end up greater than 2,400 mils per day because you're excreting all this extra glucose and the water is following it behind. There are some other causes. You can look through your class notes for the other one, but the primary cause that we see is diabetes mellitus for pre-renal glucosuria. Now, renal glucosuria, we start out with a normal blood sugar, 100 milligrams per deciliter. So we start out with normal. The glomerular filtrate filters out 130 milligrams per minute. However, something is wrong with that proximal convoluted tubule, and because of that, we're not reabsorbing. The body cannot reabsorb the full 130 milligrams per minute. It only reabsorbs the 70 milligrams per minute, and therefore 60 milligrams per minute gets excreted out into the urine. So renal glucosuria, there's an issue with that proximal convoluted tubule where the body cannot reabsorb the sugar back in. Fanconi syndrome is going to be one we see quite a bit with this. We don't, to be fair, we don't see this often, but we do. Fanconi syndrome is one that we see. It's impairment of the proximal tubular function. Okay, Fanconi syndrome. Anytime the proximal tubule is not working, it's going to be kind of fall into this category of Fanconi syndrome. Advanced renal disease is going to sometimes cause this. Cystinosis. Cystinosis is a genetic disorder where the deposition of amino acid cysteine happens in the cells due to a defect in the cysteine transport. Cystinosis is the most common cause of Fanconi syndrome. So cystinosis is going to be the most common cause of that proximal tubular function disease. Heavy metal poisoning is another one where I see, lead poisoning. We thought we had taken care of this in the 70s and 80s, but sometimes these old houses still have a lot of lead in them, and so we still see this today, lead poisoning in kids, but other heavy metal poisonings. Hyperglycemia without glucosuria. In this situation, we have a blood sugar of 300 milligrams per deciliter, so definitely elevated. But for whatever reason, the glomerulus is only filtering out 60 milligrams per minute. And the body can reabsorb that 60 milligrams per minute just fine, so there's no glucose in the urine. So we got high blood sugar, but our urine has no extra glucose in it. So what types of testing do we do? What types of specimens do we do for glucose testing? Random. You go to the doctor, you pee in the cup, just whenever you happen to be there is when it happens. 2-hour postprandial. You eat a meal, and 2 hours later, you're going to do a blood and a urine and see what's going on. And then we have glucose tolerance testing, where you drink the ick, so you get a baseline, so you get a times 0 urine and blood, and then you drink the stuff, and then you have a half an hour, 1 hour, 2 hour, and 3 hour testing to determine how the body handles it, what's going on in the bloodstream and in the urine, to see what correlation we see in that situation. So how does the strip work? The strip works, it's a glucose oxidase reaction. It's a double sequential enzymatic reaction. Whenever you see a double enzymatic reaction, this is one of the things we're looking at. When you're talking about urinalysis testing, double enzymatic reaction. First enzyme is a glucose oxidase. The second enzyme then is going to be the peroxidase. So 2 enzymes, double enzyme reaction. I'm going to make for a color change. Depending on the reagent strips is going to depend on what chromogen gets used. Chromogen really is just a color-producing substance. So in the strips, depending on which strips you're using, you might end up with different colors depending on what chromogen they pick for the different strips. Interferences, false positives, oxidation of the strip due to other things. Chlorine bleach, and other strong oxidizers. We don't use chlorine very often in the labs anymore. We don't use bleach, but we have to always remember strong oxidizing cleaning agents can cause a problem. In our lab, that is why we always put our little placemats down, and we always work on the bibs, because we don't want anything on the counters because it could affect. If we put the strips on the counter and something was used to clean the counter that's an oxidizer, it could affect our strip results. Exposure to air, the reagent strips. You pull one out and put the lid right back on, because exposed to air is going to create oxidation, which is going to create a false positive. False negative, large amounts of ascorbic acid. 9 times out of 10, if somebody asks you about a false negative interference, ascorbic acid, if that's one of your options, it's a good guess, because ascorbic acid interferes with a lot of these tests, including the glucose oxidase, and it will lead to a false negative reaction. Ketones, sometimes the combination of high ketones and low glucose, you're not likely to see it. Usually you're going to see it in high amounts of, with high glucose. Certain preservatives, sodium fluoride in particular, but other preservatives, always know what preservatives you're using and what you're looking for. Always go back to those charts when you are using a preservative to know what you're doing. The other issue that can cause false negatives or reduced reactions is if the urine is fresh out of the fridge cold. We want to make sure these urines get to room temperature before we test them, because the cold urine is going to slow down that enzymatic reaction, and so you're likely to get a lower result. Now, galactosuria. Galactosuria is the presence of galactose in the urine, and we see this sometimes in newborns, and it indicates galactosemia is what's happening. So this is a serious inherited metabolic disorder, and what happens is they drink the lactose from the milk, mom's milk or dairy milk or whatever milk they're getting, they drink the lactose. The lactose gets broken down to glucose and galactose, but they're missing that enzyme there. Do not memorize that enzyme. I'm not going to make you know it, but they're missing that enzyme, which is going to take the galactose and break it down to glucose further. So then what happens is that galactose gets accumulated, and it accumulates in certain organs, and it becomes toxic to some organs, especially the liver. So you can end up with liver enlargement, you can end up with mental retardation, you can end up with cataract issues because of the galactose accumulating in these tissues. Symptoms for galactosemia in infants is failure to thrive. These babies are born, and babies grow and develop really, really fast once they're born, but these babies just don't develop as quickly. They don't grow, they don't put the weight on, they're failure to thrive. That's the primary system we kind of look at. Also vomiting and diarrhea within a week of birth, because they're not tolerating the milk products that we're giving them, and so because of that, they end up with vomiting and diarrhea. How we solve this is we remove the foods that contain galactose and lactose from the infant's diet. So obviously it becomes kind of difficult. This is where those state funds come in to help with the special diets of infants. So neonatal testing for galactosemia. Galactosemia is part of the Wisconsin newborn screen panel. All babies are supposed to have that by law. Occasionally we get babies in the state that were born in another country that maybe didn't get it. We get babies that for whatever reason missed out, or the newborn screen was invalid and never recollected. Things can sometimes happen. So it used to be every child under the age of 2 that came into the lab that had a urine test done, we would do the Clinitest on them. The Clinitest about 10 years ago, we started having problems getting some of the materials. When we had problems getting the materials to do the tests, a lot of facilities just decided to start taking it out of their testing catalog. Now, if you want one, you have to actually submit to a specialty reference lab in order to get it. If you end up detecting galactosuria, we suspect galactosemia, there are certain chromatography tests that can be done to determine which reducing substance. Because when we do this test, all we know is there's a reducing substance there. We don't know for sure what it is. So the Clinitest name is kind of like Kleenex is to facial tissues. Clinitest is a copper reduction test. So we call it the Clinitest, but it's like we call Kleenex everything that comes in a box that we blow our nose on, we call Kleenex, when it's actually facial tissue. So same idea. It's a copper sulfate plus a reducing substance is going to reduce it to cuprous oxide. So when you do this, we're going to end up getting anything from a blue color to an orange-red color. What this is that classic Benedict solution. Remember that first lecture we talked about the first urine test we had, the first lab test we had that we could get those consistent results? We use Benedict solution. What they've done is they've taken Benedict solution, they put it into a tablet form. And so what this will look for then is any sort of reducing substance in the urine. So the test methodology, sensitivity first off is 250 milligrams per deciliter. Now if you remember, the sensitivity for the glucose on the strips is 50 for the chem strips, 100 for the multi-sticks. So this is not any more sensitive. It's actually less sensitive. This is not a confirmatory test. This is a test done looking for galactose. It's an addition test looking for a specific sugar as opposed to being specific for glucose. It is not any more specific than the test. It's not better than the test, the dipsticks. This test is specifically looking for other reducing sugars other than glucose. So the 5-drop method is going to be our normal method. We take 5 drops of urine, add 10 drops of water, and then we add the tablet. When you add the tablet, it boils, it gets hot. We have this exothermic reaction. Hold the tube by the top. We don't want to hold it by the bottom or you will burn your fingers, you'll drop the tube, you'll break the tube. Hold it by the top. I'm going to tell you right now, it's like you say, oh, that plate's hot at a restaurant, and everybody touches the plate to really see if it's hot. A lot of you guys are going to be like, oh, does it really get hot? And you're going to touch the edge of it. Just tap it, you'll feel the hot. Do not hold your finger on it or you will burn your finger. So please be aware, it does get hot. So then, after it's done boiling, you sit for 15 seconds. You time for 15 seconds. After 15 seconds, you shake. Do not shake it until after 15 seconds after the boiling stops. At that point, you're going to do a little shake and you're going to interpret the color. Now, you want to make sure when you're actually doing this that you're watching it happen. You don't want to just put it aside and not watch it because you want to see when it goes through this color. Does it go to orange and then come back to this weird yellow-brown color? If so, that is called a pass-through reaction. It goes all the way through the positive and back, all the way through the forest and back. That happens when glucose is greater than 2,000 milligrams per deciliter. And in this situation then, we do a 2-drop method where we use 2 drops instead of the 5. Then you have to use the other side of the color chart to do your interpretation. So we do not have these fancy little stands in the lab. You'll have to use a regular test tube rack. But you can see they have the urine and the water. We add the tablet, the boiling happens, and then you compare it to the color chart. So Clinitest is not specific. It is very non-specific. It is good for any reducing substance, not just glucose-reducing substances. They can include galactose, lactose, homogenistic acid, fructose and pentose, uric acid, creatinine, ascorbic acid, chloroform, and formaldehyde. It is not a specific test. Therefore, when you get a positive, it is positive for a reducing substance. We don't know what, then you have to go on to further testing to determine what it actually is positive for. Anytime we have galactose, lactose, or homogenistic acid, it is clinically significant. So if one of these is positive, we have to go through chromatography and look for what it is actually positive for. Most of the time, when we have a positive, we're going to see it due to the presence of ascorbic acid. Ascorbic acid is a reducing substance. People take vitamin C. You're going to end up having a positive result due to the vitamin C. Sensitivity, 200 to 250 milligrams per deciliter. It is not as sensitive as the dipstick. The dipsticks are 50 and 100 milligrams per deciliter of glucose. This is much higher sensitivity, much less sensitive, higher threshold. Again, it is not a confirmatory test. We are specifically looking for something other than glucose. If we're looking for glucose, the dipstick is great. If we're looking for something other than dipstick, other than glucose, then we have to do this test. So, false positives of the Clinitest, large amounts of ascorbic acid. And it's really not a false positive, it's a reducing substance. We're looking for it. Low specific gravity can sometimes cause an elevated glucose level, large amounts of nalidixic acid, cephalosporin, and certain other medications. False negatives, if you mix it before that 15 seconds is over. So if you mix it while it's boiling or right after it's boiling, you can get a false negative. Also, the presence of radiographic contrast media is going to affect this test and could cause a false negative. Do's and don'ts. Do not touch the bottom of the tube. It's going to be hot. Do not touch the bottom of the tube. It's going to be hot. Hold the tube by the top so you do not burn yourself. You want to keep the container sealed. They actually come in little foil envelopes now, so when we open it and drop the tablet in, we don't have to open it, expose all the tablets to air. We used to ruin entire bottles of this because they get exposed to the air so quickly and ruin. White tablets, the tablet here on the left, that's what we're looking for. White tablets with light colored speckles. If you start getting that right one there where the speckles are really, really dark, that's bad. We do not want to use those tablets. We are going to get false results with that. White tablets good, dark tablets bad. If the tablet fizzes or foams too much, that's protein causing that, in which case we're going to add a little octyl alcohol to decrease the foaming of the protein. We don't actually do that in our clinical lab, in our lab setting. Just know, though, that if you do have a high protein, you will have to add the octyl alcohol to decrease the foaming. Make sure you always watch for that pass-through reaction. You got to watch it while it's boiling to make sure that doesn't happen, or if it does happen, make sure to note it and go on to the 2-drop. So, some comparisons of the glucose oxidase and Clinitest. So, glucose oxidase is positive, Clinitest is positive, glucose is present. 1+ positive glucose oxidase on the strip, negative on the Clinitest, is a small amount. Because remember, the Clinitest isn't going to detect it until it hits that 250 milligrams per deciliter. A small amount on the pad might only be 100 milligrams per deciliter, so it's going to detect it on the pad a lot faster. A 4+ positive glucose oxidase and a negative Clinitest, possible oxidizing agent interference. Something is making that strip test positive, and if the strip test is positive, it's a real positive, the Clinitest should be positive also. If the Clinitest is not positive, it's a false positive on the strip. And then the final one, the glucose oxidase on the strip is negative, the Clinitest is positive, non-glucose reducing substance present. So, kind of keep those in mind when you're going through these interpretations. Here are some key terms for your urine glucose. Definitions, make sure you know these definitions. Objectives, more objectives, and even more objectives. Some questions. Positive glucose reagent strip and negative Clinitest tablet, what causes it? We talked about that. Smaller amount of glucose will show up on the pad and not on the test. Oxidizing agents are going to cause that, positive results. Negative glucose strips and positive Clinitest tablet causes, we're looking at that. We're looking for vitamin C, ascorbic acid. It's going to make the strip negative, but it'll show up on the Clinitest, or other reducing substances other than glucose. There's all those answers. Okay, now we're going to jump into ketones. So, normal formation of ketones, it's an intermediary product of fatty acid metabolism, so catabolism, breakdown of fatty acids. Ketone bodies include the acetoacetic acid, beta-hydroxybutyrate acid, and acetone. When we see these on strips, not all strips are going to test for all, because if we see one, we're going to see the others. They go back and forth and volatilize over time. So if you see any one of them, it's there. We just know the ketones are there. So you really only have to test for one. Normal levels in the blood, 2 to 4 milligrams per deciliter. Ketones in the urines, less than 2 milligrams per deciliter. So very, very small amount in the urines. We don't see a lot of them. Routine urine tests are not going to be sensitive enough to catch these in those small amounts. So we're not going to see them in these tiny little amounts because it's a normal amount. We don't care. Now, conditions that can cause ketonuria and ketonemia. Anytime we're going to see fat breakdown is rapid, we're going to see ketones. So, diabetes mellitus is going to be the most common times we see this. Lack of insulin, cells are unable to take up glucose, the body senses starvation. We're going to have fat metabolism that's going to occur, keto acids are going to accumulate, pH is going to go down, bicarb gets lost in the urine, large amounts of glucose, ketones, and water get excreted, and you end up with this chemical imbalance. Other conditions that can affect it, insufficient carbohydrate consumption, the keto diet, right? It goes through those little spurts where it jumps and jumps and jumps. Fat breakdown is not as rapid, so only ketonuria occurs. We're not going to see ketonemia, thankfully, because we don't need extra ketones floating around the bloodstream. The bloodstream has narrow ranges of things that are good. The excess will end up in the urines. Conditions we'll see this: starvation, fever, diarrhea, vomiting. These GI bugs that we get, they can cause it. Usually it's pretty self-limiting. High protein, low carb diets, fasting, anorexia, and then severe exercise can cause it. So multi-sticks test for acetoacetic acid and acetone. Just acetoacetic acid, It does not detect the acetone, and its sensitivity is 5 to 10 milligrams per deciliter. Remember, these product inserts are available for you to look at when you're answering your homework questions. The chem strips pick up acetoacetic acid and acetone, and then there's these Acetest tablets. We're not really going to spend much time on them, but we do know they exist out there. I don't know any labs that actually still run them, but they exist. And they're going to look for acetoacetic acid and acetone also. False positives. Phthalates, large amounts of fetal ketones, and certain preservatives are going to cause false positives. Now, low-level false positives, high specific gravity, could cause a false positive. Large amounts of levodopa metabolites, it's a treatment for Parkinson's. So certain people are being treated for Parkinson's. We are likely to see low-level ketones. It's metabolites of the breakdown of the drug that we see in the urines. We are also likely to see a false positive with any sort of intense red or atypical colored urines where they stain the pad. So again, anytime you have an unusual color urine, think about what pads can be stained and the color altered because of that coloring. False negatives, improperly stored specimens. Ketones volatilize. So they kind of like evaporate into the air. So it's really important that we test these quickly because the longer they sit, the more evaporation that occurs. A little bit regarding the ACE test. It will detect acetone, which multi-sticks don't. You can use it with blood as well as urine. Can be used when you need to make urine dilutions. So if you have to make dilutions out, it can be used to kind of figure out how much is actually out there. Here are your key terms and your objectives. Few definitions, make sure you know these definitions.